Hello, welcome to this next session in your point of care ultrasound program. My name is Tom Heller and I want to give you some ideas about focused assessment with sonography for HIV-associated TB, also known as FASH. Let's remember first what is FAST, and you remember that from the last module. That was focused assessment with sonography for trauma patient, and the main aim of that protocol was the detection of pericardial fluid, the detection of pleural fluid, and the detection of free intra-abdominal fluid. And for this, a standardized set of 6 views was used to assess the patient for these effusions. When we came to Africa, we thought, what could FAST do in Africa? And of course, here you see a situation which is definitely FAST. You see a very critical situation and your patient is in mortal danger. And to rescue him, you need to be quite quick to outrun the cheetah. But of course, that is tricky for most of us. And actually, most of our patients are not in danger from cheetahs, but there is another problem that is far more risky for our patients here. And this brings me to this patient in a TB clinic in South Africa. This is a 23-year-old HIV positive woman. She complained about loss of weight and night sweats and as well as cough for 3 weeks. Well, everybody will agree that this looks very much like tuberculosis, but her sputum AFB was negative and her urine LAM was negative. So there is somehow a little bit of evidence missing. Still, you could decide to start TB treatment based on the clinical grounds, but another thing that we did is we did a chest X-ray. And this is her chest X-ray, and you can see this very typical left upper zone infiltrate, very consolidated, even with an air bronchogram. And of course, an upper lobe infiltrate is very suggestive of TB in our settings. And given this chest X-ray, we felt better and we started her on TB treatment and she got quite quickly better. The same would have been true if she had this chest X-ray, which shows a large cavity here, which is another typical sign of pulmonary tuberculosis. Or this one, an right upper lobe infiltrate, right upper zone infiltrate, again with a cavitation up here, very consolidated, typical picture of radiological TB. Beside the X-ray, we can also look at So let's summarize. We have seen a patient who clinically has the clear signs and symptoms of TB, and we are suspecting TB. We are in a setting where TB is very prevalent. The patient has an immune compromised, which makes tuberculosis even more probable. And in this setting, we find an imaging feature, which is the infiltrate, the cavity, and based on that, we decide that we want to start this patient as a smear-negative patient, smear-negative tuberculosis for treatment. The WHO already in 2007 published guidelines on the diagnosis of smear-negative and of extrapulmonary TB, because this is a big problem in our patient population of HIV positives. The smear and not a very good test, and in that guidelines you find this table, and that is a table of the 5 most common and most important, we might say, forms of extrapulmonary TB. There is the lymph node tuberculosis, the pleural tuberculosis, the disseminated tuberculosis, the pericardial tuberculosis, and finally the tuberculosis meningitis. And as you can see, the pleural effusion is a unilateral pleural effusion is considered quite suggestive for TB and deserves empirical treatment in the right setting. The same is true for pericardial effusion. So that is another finding that we can diagnose with our FAST scan, so these are two of the 5 forms which can already be diagnosed with ultrasound. And of course, now we thought from Africa there has to be something new, and we renamed and revamped the FAST scan, and we coined the term focused assessment with sonography for HIV-associated TB. And as this table before showed you, pericardial fluid and pleural fluid are clearly already can be refurbished and reused in the FASH scan. And on the others we will have a look at now. Thank you. So we are back in the clinic, another patient, this time a 22-year-old female patient with complaining again that she has lost lots of weight, and additionally she has intermittent diarrhea, complained about mild abdominal discomfort and a bit of hiccups. On her examination, her abdomen was mildly tender but definitely without peritonitis, and in her lab investigations we found everything more or less normal except for an hemoglobin of 7.1. She tested HIV, was found positive, and her CD4 count was very low with 23 cells per milliliter. And as you can see, she looks again very emaciated, she looks skinny, she has lost weight, and we decided, in analogy to the patient before, let's send her for a chest x-ray and see what we can find. The trouble is, in this patient, the chest x-ray did not show any infiltrates, or did not show any sign that gave us this little bit of kick to say, yeah, this is TB, let's start TB treatment. The chest x-ray was completely normal. What we increasingly did with these patients is that we sent them for ultrasound, and that was what we have done with her. We did an abdominal ultrasound, and we found a small amount of ascites as well as multiple hypoechoic enlarged lymph nodes, the largest being 3.5 centimeters, in the periportal and in the para-aortic area. Here you can see the liver, and behind the liver this is the portal vein. So here is the periportal area, and you see this dark hypoechoic nodule. And then further down in the middle of her abdomen, again a transverse scan with a convex probe. You see down here, this is probably the aorta, difficult to say on a still image. And you see that there are multiple nodular roundish hypoechoic structures in front, which are para-aortal, pre-aortal enlarged lymph nodes. Additionally, what you quite often see are lesions, hypoechoic small lesions in the spleen, and they were also seen in this patient. Here are examples from 2 different patients. Sometimes they can be very, very small, sometimes they are a little bit bigger, to up to 1 centimeter. And based on these findings, we said this could also be tuberculosis, because what we found, if you look a little bit systematic on the ultrasound findings of TB patients, abdominal TB, they have quite often, in more than half of the patients, they have lymph node enlargement, quite often in combination with about 50% have spleen, the spleen lesions, and then often ascites, small amounts of ascites were seen additionally. So in this combination of findings is very suggestive of abdominal or disseminated abdominal TB. And so you see that for our FASH scan, we had already talked about the pericardial and the pleural fluid, but now also hypoechoic abdominal lymph nodes and spleen micro-abscesses can function quite well in the FASH scan. Let's look a little bit more in detail on lymph nodes. How do lymph nodes look on ultrasound and where are they located? Well, generally, as you all know, lymph nodes are roundish structures and they are usually not visible in the abdomen. They are only visible when they are enlarged. They can be mostly they are hypoechoic structures. They are often a little bit elongated and flattened, and of course they are surrounded by a connective tissue capsule. A healthy normal lymph node has a central echogenic center, which is also called the hilus fat sign, due to central fat and connective tissue that sustains the architecture of the node. The size is normally smaller than, here it said 1.5 to 2 centimeters, probably it's usually smaller than 1 centimeter. Where are they located? The bulk of the lymph nodes is located in the retroperitoneum. So it is, you can see here, this is with A, this is the aorta with the branches, the superior mesenteric artery and the celiac trunk with its branches, and surrounding the aorta there is this lymphatic tissue here in green, which are the lymph nodes and the lymphatic vessels. Additionally, we find a lot of lymph nodes in the mesenteric root, that is shown here. So this is the bowel, and the bowel drains its blood towards the mesenteric root, and of course there are also a lot of lymph nodes that are there to filter the blood coming from the bowel. So these are the locations where you might expect lymph nodes. But how do lymph nodes look? And here we need to go on ultrasound, and here we need to go for something completely different. On this slide you can see a globular structure, a roundish ball. But of course the ultrasound gives us only a two-dimensional image, and if we slice this ball in two-dimensional images, we get a lot of slices, round slices, circles, and these circles are small and at the corner, at the border of at the beginning of the ball, and they get bigger, and then they get smaller again. So this is the typical appearance of a globular enlarged lymph node. It's a hypoechoic structure that comes into the picture, starts to get bigger, smaller, and this blinking appearance, that's what makes what is characteristic of abdominal lymph nodes. Let's have a look at that in a moving clip, and that's here a different patient. You can see up here there is the liver, which is used as an acoustic window to see the area here in the center of the upper abdomen, and there you can see a lot of roundish structures that grow bigger and then smaller as the transducer passes over. Maybe you focus on this one, it gets bigger and then disappears. So there are quite a number of these getting, as the transducer passes over, they get bigger, smaller, and then they disappear. And that is the typical structure. A difference to the vessels, because the vessels are tubular structures, and of course the tubular structure does not come and go, it stays in the image. So that is how you can see it. How quick do you move the transducer? Well, that depends clearly on how quick your brain can digest the information. So the more experience you get, the quicker you are, but generally it's good to move slowly and steadily over the area of interest. And you see these blinking lymph nodes. Here's another example. Again, we have here the liver, and let's see how that looks in motion. You again see that there, through the window of the acoustic window of the liver, we see multiple nodular structures here in the portal area, in the pancreatic area, and towards the splenic hilum. I think this is quite easy to spot for everybody. Leave it for a moment. And of course we can do the same thing in a longitudinal. I'm not recommending that you do that every time. Usually I really recommend to use the transverse scan and scan up and down, but you can of course turn it into a longitudinal axis, and then you do the same fanning movement, and then you can see that here these longitudinal structures, these tubular structures, these are the large vessels. This is the aorta and the inferior vena cava, but in front there are these hypoechoic structures, nodules, which come and go, which blink as the transducer fans from left to right. This clip was sent to me via WhatsApp, and you can it highlights 2 points. Number one is that it can be this changes can be quite well seen even if the quality is not that good and you send it via WhatsApp, and that's a very good way of getting a second opinion. Additionally, what you can see is that here is a nodular structure, and it is hypoechoic, but it even has smaller areas which are almost anechoic or very, very hypoechoic, and that is a very typical feature for TB nodes, because these are small, probably the caseating necrosis within the lymph node are seen here. What are the most important facts on ultrasound of the spleen, and where can we find it? The spleen is located in the left upper quadrant. That's something that everybody knows. But what is not so well known is that it is very, very dorsal. If you look at this picture here on the right side, this is a 3D reconstruction of an abdomen of a patient seen from frontal, and you can see, if you expect the spleen to be up here in the left upper quadrant, you will see that you see nothing. You see there is bowel, there are bowel loops, but there is the stomach here, but there is no, the spleen is not visible. If you want to find the spleen, you have to go. You have to go to the back side. You have to bring your transducer far around, almost to the back of the patient. So this is the turned 180 degrees now, and we're looking from the back. Here is the liver, here is the kidney, now on the other side, of course. And here you can see between the ribs, safe and secured behind in the thoracic cage, that is where the spleen is located. So if you don't find it, then it is most probably because your transducer is not far enough backwards. Your knuckles are not touching the bed. You are probably looking somewhere in the bowel gases in the left upper quadrant. If you find it, it is a bean-shaped organ. It is located under the left hemidiaphragm, and it has a homogeneous texture of the tissue that is very similar to the parenchyma of the liver. The normal size is 11 centimeters. As a rule of thumb, you could say the caudal pole of the spleen should be not further down than the middle of the left kidney. If you measure 11 centimeters, don't take that as an absolute number. In African patients, very commonly you see slightly bigger spleens, maybe 12, maybe even 13 centimeters might be considered normal, simply because of recurrent parasitic infections, and particularly malaria, that increases constantly increases the activation of the spleen, and thus the spleen gets a little bit larger. What you often see are small accessory spleens that look like they have the same texture like the spleen, and they are often located in the hilar region and at the lower pole of the spleen. They are simply an anomaly that has no pathological value. That is simply an anomaly of not completely fused splenic tissue. Let's have a look at the ultrasound here, and you see this spleen we are looking at it with a convex abdominal probe, and here is this bean-shaped organ between the ribs, which is the spleen. And you can see that the tissue here is not homogeneous. You can see there is darker areas here, there's brighter areas here, here's a darker area again. So these is inhomogeneous hypoechoic lesions in the spleen, but they are not very well visible, and that is due to the fact that we are using an abdominal convex probe. It gets much better if we use a linear probe. This is the same patient. Obviously now, because it is a linear probe, we don't see the whole of the organ anymore, but what we see much better are the details of the texture, and I think even a blind man can see that here there are multiple small micro-abscesses in this spleen. This is the typical sign, and it is highly suggestive of TB, and this patient should be started with TB immediately. Here is another example, different patient, a little bit bigger here, a little bit more hypoechoic, but again mottled and distributed throughout the spleen, this TB microabscesses. Here another example of a patient with a slightly enlarged spleen, and this is again the convex abdominal probe. Look, fanning through the spleen, and you can see that, yeah, it depends. You can see that there are some inhomogeneities, but I wouldn't mind if anybody says, I'm not sure if I would have seen that, because they are difficult to see. And that's again is a case where it helps to use the linear transducer, and then you realize why it almost looks homogeneous on the other one, because there are so many microabscesses that it almost becomes homogeneous again. But with the linear probe you clearly see the normal tissue between the focal lesions. So this again a case of miliary distribution of small TB lesions, TB granulomas in the spleen. So let's look at TB peritonitis, and TB peritonitis is probably more common than we think. From autopsy studies, it is estimated that TB peritonitis occurs in 1 to 3% of patients with pulmonary tuberculosis, and in approximately 4 to 10% of patients with extrapulmonary tuberculosis. Of course, these are not all clinically very apparent. How do the TB bacteria get to the peritoneum? Well, mainly through hematogenous spread, and then they seem to sit, and then the mycobacteria seem to like the serosa, so they like the pleura, they like the pericardial, and so they like the peritoneum, and they form latent foci there, and then are reactivated. Another possibility is that through continuous spread, particularly if the patient has bowel tuberculosis or in female genital tuberculosis, but that is probably much rarer than the hematogenous way. What do we find? We find ascites as an inflammatory reaction, and when we do a paracentesis, we find this ascites mostly straw-colored, but it can also be blood-stained. The protein content is high, leukocytes are elevated but not very high, and they have a lymphocyte predomination. So it's not so much granulocytes but lymphocytes that are there. If you try to prove the TB, acid-fast bacilli again prove very acid-fast stain prove very not very sensitive, and they are often negative. And what you can try is to put it in a Gene Expert, in particular in the newer Gene Expert Ultra. What is the gold standard of biopsy of peritoneal TB is the peritoneal biopsy, but that of course needs laparoscopic guidance. It might be possible to do it ultrasound guided, but that's not as well established. So that is, but of course laparoscopy is often not available in our setting. If you do a laparoscopy, this is a laparoscopic image. This is the abdominal wall, and here you see bowel, and you see these white small granula in the serosa in the peritoneum. If you biopsy, you find this here. This is a histology. You find these granulomas, well walled off granulomas, and in the middle there is this caseating material that is characteristic for the tuberculosis. How does TB peritonitis look on ultrasound? Well, it looks mainly like ascites. It might be clear, then it's homogeneous black. It might be complex, and complex is when you have these fixed membranes, septa, strands within the fluid. Additionally, you often find a thickened peritoneum. Sometimes even you can, with a linear probe, you can even see the small nodules, and then you find the other findings that we talked about. It's accompanied by lymphadenopathy and by spleen abscesses. So, of course, the ascites alone could be a sign of TB, but we have to remember that there are other differential diagnoses that could explain ascites. So now we have already quite a few of our FASH findings ticked. So we had the detection of pericardial fluid, detection of pleural fluid, and now in the final we added the value of free peritoneal fluid. And we spoke about the upper abdominal lymph node and the spleen micro-abscesses. In some of the older publications, you will see that there can also be focal liver pathology, small lesions in the liver. These are relatively rare, and they are very rare that you find lesions in the liver without having at the same time lesions in the spleen. So that's why for most trainings today, we do not propagate the look for focal liver pathology, because that is also a little bit more difficult and needs more training. So we discussed the findings that we can see on ultrasound and that can suggest tuberculosis, disseminated tuberculosis. But of course, it is only a suggestion, so that we have to talk a little bit about whether the diagnostic value and about differential diagnosis. And in our study in Hlabisa in KwaZulu-Natal, we started all our 30 patients on anti-TB treatment, and most of the patients were on ART if they were not already on ART treatment. And then we followed them up after 3 to 4 months, and we reached out to 25 patients after median of 17 weeks, and 19 of those 25, so that's 76%, were still taking her TB medication, and they reported clinical improvement and said, thank you, you did the right thing. 24% had died. So now, of course, this is not large data, but what does it mean? To get the diagnosis right in 76% of the cases is generally already quite good. With the 24%, it would we don't know. Maybe the diagnosis was still right, because obviously these were very sick patients with advanced HIV disease, with disseminated TB. So even if you initiate the correct TB treatment, some of them might still have a risk to die. So in general, we concluded that for our setting, where we don't have many more tools to diagnose TB, it was sufficient enough to deserve empirical or ultrasound supported TB treatment for patients who had these findings of hypoechoic abdominal nodes, splenic micro-abscesses, and ascites. It is simply the fact that in a place where TB is very common, it is very probable that these findings are due to TB, and it is a treatable condition. So you better start the patient on TB treatment. If it later turns out to be wrong, then you can still see that. But it is simply like it's said in the House of God: if you hear hoofbeats, it is more likely to be a horse than a zebra, unless you are in a place where zebras are more common than horses. Then it is different. And let us look at one case here from Malawi. This is a young girl which was seen with suspected TB, 13-year-old female, diagnosed HIV positive, started ART, and then she had typical symptoms: fever, night sweats, weight loss, back pain, and FASH was done, and it was found positive. There were lesions, so she was started TB treatment. But then a month later, she returned with worsening symptoms, and the clinician asked me to see her, and we scanned her. And this is her scan. And of course you can see here there are these typical nodular structures which we discussed now during this session. Additionally, you see that there is inside the liver there is a larger lesion. Well, when you look at the spleen, again you see there are hypoechoic multiple lesions which are quite large. But because we put her on treatment and she's clinically not getting better, we said, maybe we're looking at something different here. So what we did is we did a biopsy of these lymph nodes, and it turned out that this was a lymphoma. So the patient needed to stop TB treatment then, and he was started on lymphoma chemotherapy. But of course, doing a biopsy on everyone is quite cumbersome and quite expensive, and often you don't have the pathology services. Very often you don't have the chemotherapy services to treat a lymphoma adequately. So that's why we still stick to the assumption that let's first think it is TB, and let's start TB treatment, which is easy and widely available, and in most patients we will do the right thing. We can use ultrasound to monitor the FASH findings, and if you see, this is a series which we published from Italian patients, because they did very regular ultrasound at time of diagnosis at months 1, 3, 6 and 12 months. And if you see that these are the findings: abdominal lymph nodes, spleen abscesses, liver abscesses, and after 1 month already a lot of them is gone, and half of them the findings are gone, but by 3 months almost the majority is gone. If they are not gone by 3 months, then you will probably look at something where they persist very much longer, and you probably look at problems. And what are the problems that we need to consider if the clinical signs and the ultrasound findings do not get better? Well, we need to think whether the patient is adherent. We need to consider whether this might be due to immune reconstitution inflammatory syndrome, that he or she start ART, and that can lead to persistent and increasing size lymph node swelling. Is it maybe resistance? Is it extrapulmonary MDR TB? Of course, the extrapulmonary TB can be as resistant as the pulmonary. Or, as we saw in the case of that girl, is it maybe simply the wrong diagnosis? And that is the moment when we should start to try to get some material and to be more invasive and to get a biopsy. So let us look at some other aspects of FASH. And one question that is interesting is, what does the ultrasound really add onto the conventional chest X-ray? You remember our patients, the small patient stories that I told you in the beginning. There was this patient with the suggestive symptoms and signs. We did a chest X-ray. We found an upper lobe infiltrate, and we decided this is TB. And then there is the other diagnostic way, that we have the patient coming similar symptoms, similar case, done a chest X-ray, no typical changes, and then we do the ultrasound and find findings suggestive of TB. How common is that situation? And what we looked in between various case series from South Africa, that was ours, from Italy, from Saudi Arabia, there were a total of 82 patients with FASH diagnosed extrapulmonary tuberculosis who had additionally a chest X-ray. And if you look at what the chest X-ray shows, then it's quite interesting that in 20, so in 1 in 5 patients, the chest X-ray shows a miliary TB pattern, which goes, of course, with the disseminated TB that we are expecting in these patients. But, and that is even more relevant, is that 26%, so a quarter of the patient, has chest X-ray which were not suggesting TB. So these patients were solely diagnosed because of the ultrasound assessment. Of course, the way we think, or we traditionally thought, is that TB is a pulmonary disease, so the first investigation should be a chest X-ray. But reality is that that of course in many places it's not that easy to get a chest X-ray. An ultrasound is much easier. It has no radiation. It just needs somebody who is skilled and has basic skills in ultrasound, and then it needs a little bit of gel. So you can do it in the clinic, you can do it in a peripheral hospital. So we could think the whole thing in reverse. What we should maybe do is if we have the suspicion of TB, we should do an ultrasound. If we find the typical findings of TB, we will start TB treatment anyway. If we have a different patient, we do an ultrasound and we do not that are hinting towards extrapulmonary TB. Then we send them for a chest X-ray, and then we might find the additional patients. So that would be probably a better approach, especially for places where you do not have a chest X-ray readily available. Now, in recent years, more and more relevant became the urinary LAM test. And that is a test also for disseminated tuberculosis, where you find the antigen in urine, and it is particularly helpful in patients with very low CD4 cells. What we looked at is how do LAM and FASH actually compare, and we looked at 100 patients that were seen at Lighthouse, and we did a LAM and a FASH ultrasound for them. And if you look at the key findings are here, there is a large overlap. So 50% of the patients had both FASH and LAM positive. So we diagnosed them twice, you could say. But 20% were diagnosed by LAM, but had a normal FASH scan. And 30% were diagnosed by FASH, but had a negative LAM. So that shows you that it is an overlapping between the two tests, but it is not. It does not 100% detect the same patients. We looked then whether there is any change, depending on the level of CD4, but there was not really much difference there. If you look at the findings, the ultrasound findings, we thought in the beginning that particularly these splenic hypoechoic lesions, which are like a miliary pattern, which look very disseminated, that they might be more closely correlated with a positive LAM test. But frankly speaking, it was not much difference there neither. You see that splenic hypoechoic lesions were seen in 69% of the patient with a positive LAM test, and in 74% of the patient with a negative LAM test. So the tests detect similar things, but they do not detect identical things. So that's why they have to stand next to each other, and they are complementary, and one does not replace the other. One question that troubled us from the beginning is how can we teach this? Because I mean, it's nice to have a protocol, but if you cannot roll it out widely, it will be of little use to the patient. So what we tried already in South Africa in 2010 to create a short course protocol for FASH ultrasound and teach it to clinicians. And to cut the long story short, it can be taught in courses like this, which you are attending, and in a weekend you can learn the basics of FASH, and if you practice, you will recognize and you will find the findings. That is what this article showed. And in the month or in the time afterwards, here you see a program from the Emergency Medical Society of South Africa in 2011 in their workshop on point-of-care ultrasound. They already had a module 12 FASH assessment with sonography for HIV and TB. So FASH became fashionable. And even more so, from all the modules that are used in South Africa, you see here, this is FASH is down here. It is the fourth most common module, and it is, and I think it is even more frequently, because in their nomenclature, pulmonary, which detects pleural effusions, and cardiac are individual modules. But of course, given that most of these are also done with the question of is there TB, so if you put it all together, it's a very, very frequently used and relevant protocol. So, but I have still only showed you small suggestive studies that we did ourselves, but in the meantime, there is in the literature, there are good large number patients studies, like here, this one from Cape Town on 377 inpatients HIV positive suspected with tuberculosis in Cape Town. Of course, a TB high prevalence area. They had they were scanned, and particularly they were included when they had these danger signs, and an abdominal ultrasound was performed with a convex probe and a linear probe, and then they were and a very extensive TB diagnostics were done. And what you can see is that here in the table, that enlarged lymph nodes have a very high odds ratio. They are very, very associated with finding TB in the end, and also the spleen hypoechoic lesions are quite close correlated with final diagnosis of tuberculosis. Also, the effusions are maybe less so because, of course, as we discussed, there are differential diagnoses that can confound it for particularly for ascites, but still there is a strong correlation. And to bring it to an end, in the Malawi National Tuberculosis Guidelines, there are these guidelines mention the FASH ultrasound as one tool to diagnose extrapulmonary TB. So a FASH positive is sufficient to start TB treatment. And with this, I like to end, and thank you very much.